To talk about some of our research that we've undertaken over the past couple of years and looking at quality of life and well-being and trying to explore the interesting distinction between those two and actually trying to put forward an argument about how they are different, how well-being is actually more important than perhaps quality of life is, and how us as practicing clinicians can actually improve well-being across the piece. So it's myself and Penney acting as a double act. Penny's going to do all the clever stuff. I'm here just for the glamour, really. So it wasn't a joke.
No, he truly believes this.
So I'm going to start off by passing over to Penney, who's going to introduce quality of life and well-being. Then I'm going to come back and we're going to move between one another. I should say, for you, for those of you that were in the workshop sessions yesterday, you were all voting with the voting buttons. We have used some of that data in our presentation, which we wrote last night after the meal. So hopefully it's all right. Hopefully nothing goes wrong. I think there was one of you that said, have you got ethical approval for using it for your research? It wasn't research. It was audit. Honest. So I'll pass over to Penney to introduce the...
Okay, I mean, what we really, as Dominic said, want to do is tell you a little bit about some of the work we've done and some of our ideas around quality of life and well-being. So some of you will have heard some of this stuff before, but not all of it. We're going to build very much on the things that we talked about yesterday in the workshop. But just as a little bit of a reminder, what we'd say about quality of life is that it's a very broad concept. It covers a whole range of issues from social, economic and health. And it's something that's been used by professionals in many different spheres. So economists often talk about quality of life. And they'll talk about quality of life in terms of how much money we've got, what our standard of living is related to economic factors. Sociologists talk about it as well. But we use it an awful lot in health. And in health it's become a very, very important outcome that's measured. So it's linked to health status and how well a person is. One of the things to say around it is that means that the focus is very much on limitations of functioning, and that's something that I'm going to come back to as we sort of move through the first part of this presentation. I think the other thing to say around quality of life is that actually, whilst it was very broad at its initial conception, very much the way it's applied in health has narrowed the focus to a great extent. Well-being is another broad concept, and very often well-being and quality of life are seen as being the same thing. They're used as synonyms. One of the things we're going to argue is that actually that's no longer a good way to see quality of life and well-being, and that actually it's quite important, particularly in the health sphere, to separate those two from each other. The important thing around well-being is the fact that its focus is on growing psychosocial resources. So it's about positivity, and it's about having the resources to deal with and cope with various situations. And hopefully by the end of the presentation you'll see why we're sort of conceptualising it in that way. So, is the difference important? Yes, we believe it is. And again, these are some of the things we talked about yesterday, but to build on them, and for those of you who weren't in the workshops, quality of life is very much around someone's cognitive appraisal of their own current situation. So in terms of health, that's how people think about the condition that they have, how they believe it affects them. And you do that in many different ways, and one of those ways might be about comparing yourself to somebody else in the same situation. It could also be comparing yourself to who you used to be and how you functioned when you were well. We do sometimes measure emotional responses when looking at quality of life, and originally, as I say, it was a broad concept. The idea was that when you measured quality of life, you looked at physical functioning, you also looked at psychological functioning, social functioning, and emotional functioning. The thing is, though, the measures that have been developed all focus on the negative emotions. Now, I find this quite interesting as somebody who's been involved in psychometrics, who's developed a number of measures linked into quality of life, is very often you start off with all those positive things in the measure. By the time you end up with your final piece of work, they've all disappeared. And I think there's a big question to answer around that about why that should be the case. But the important thing to focus on today is the fact that that means that we have what is a deficit model. So we're always looking for limitations. We're looking for the negative. We're looking at how your health has a negative impact on who you are and how you behave. Okay? And I think that's quite an important thing to focus on. In contrast, well-being is much more about somebody's emotional responses. It's much more about how you feel, how your condition makes you feel. But it's more than that. It's about all sorts of other things that come to play, all sorts of other things that impact on how you feel as an individual. But the great thing about well-being is the fact that it's so positive. It's about having positive emotions. It's not enough to say that if you don't have any problems of emotional functioning, then you're okay. You have to have the presence of positive emotions. So going back to those measures of quality of life, where they ask about emotion, they might be asking, are you worried? Are you anxious? And yes, they're important things we need to know about. But just because somebody doesn't feel worried or anxious doesn't mean they have positivity. It doesn't mean they feel hopeful or optimistic. Just because they don't have poor quality of life doesn't mean they have good well-being. And that's why we feel it's so important to separate these two apart. I think also the fact that you can therefore see it very much as an asset model is a really good way of taking our understanding of health and how health impacts on individuals forward. It's so positive. It's not about looking for problems, it's looking for good things to take forward. And the way we've conceptualised it and the way we're going to explain it to you today is that rather than looking at something which is an outcome measure, which is an endpoint, which is very much what quality of life is seen as and is used for, we're looking at mediators. We're interested in mediator variables, something that acts between having that health condition and having well-being and being a well person in a sort of a broad kind of conceptualisation. And the reason we think that's important is because rather than saying, tick at the end, yes, your quality of life's okay, what we're trying to say is, what are the factors that impact on an individual when they have a health condition? Can we do anything to work with these? Can we help people actually improve things for themselves? So I just want to say that actually we've done some work around this. We've done some literature review. And what we would say is people are recognising more and more that there is a difference.
Do you mind just speaking a tiny bit closer?
Right, okay. That there is a difference between quality of life and well-being. And just to illustrate this with a quote, there's some work that's been done recently that some of you will probably recognise this quote. But it's stated very clearly that whilst health-related quality of life instruments provide quantitative information, they're designed to look at deficits in functioning and may not capture what people think and feel about living with a wound. And we would absolutely agree with that. One of the things that we found when we were doing our review is we found lots of measures, lots of papers where people had looked at quality of life. And they might have used specific measures. Some of them had used generic measures such as SF36 and Euroqual. These are perhaps the patient-reported outcome measures that you've heard of before. Lots of work around that, lots of work looking at the impact on people in terms of the negative functioning. We found it much harder to find things on well-being, and I think, again, a quote from this particular piece of work illustrates perhaps why that's the case. And they say, well-being is subjective, fluctuates over time, and is typically difficult to measure. Focus needs to be placed on self-reporting and observational methods to enable processes that support individuals living with a wound to help achieve their potential and increase overall satisfaction with life. And I think what's interesting, as I say, is we found very few papers that had really looked at well-being. And when we did, just to give you an example, the Cardiff Wound Impact Schedule, which I'm sure is very well known to people, does have a scale on it which looks at well-being. But what's interesting is if you actually look at that scale, there's only one item which asks about positive emotion. So whilst we're starting to make headway in this area and there is recognition of the difference, we're not there yet. We still have to do some work around this. As we said, just to give you a little bit of feedback from yesterday, We're very interested in what people think about quality of life and well-being. We're very interested in how important you see it as being. So we asked everybody who came to the workshops, which do you think is more important to your patients? Is it quality of life or is it well-being? And I think we were actually quite pleased to see that the majority of you were saying well-being. So there's clearly recognition in the room that this is a very important concept. So given this, given the fact that we recognise the difference, the fact that we're moving more and more to putting an emphasis on well-being, what we'd like to ask is, why is there no measure of well-being? And what is it? And why is it so important? And I'm now going to pass you over to Dominic, who's going to take you through some of the other factors related to well-being.
I am indeed. In fact, I'm going to do the negative bit. So, again, yin and yang, or yang and yin. This is I was going to say traditional, this is a usual conceptualisation of what well-being is. Involves 4 different elements, but I haven't been able to get the 4th one in, which is that sort of cultural or spiritual element that sort of overpins everything, overarches everything. Well-being sort of consists of 3 sort of fundamental elements. These are the negative factors which may impact upon well-being: the physical, the social and the mental. And I'm not sure, I hope you can see, well, you probably can't see because I can only hardly see, the yellow boxes at the bottom. You can break down each of those elements into smaller components. So under physical, for example, we have diagnosis, we have treatment, we have pain. Underneath the social elements, we have isolation, we have impact on family and friends, and we have stigma. Similarly, under the mental or the psychological component, we have depression, stress, worry, and uncertainty and frustration. And I'm going to go through each of those in turn, looking how each of those can impact upon well-being. I'm then going to pass over to Penney again, who's going to do the positive side, looking at how some of those elements can be balanced out. Because we do indeed think that it's a balance. And if we conceptualise well-being, again, this is a slide that we showed yesterday, pressing down the negative sort of elements, wound, treatment, pain, odour, exudate, social isolation and psychological consequences. All of those are the negative sort of factors which may impact upon well-being. In contrast, there are protective factors which are pushing up, trying to rebalance this whole model. They may be coping resources, they may be resilience, personal psychological resilience, they may be personality, the hardy personality. There may be optimism, and of course, importantly, there may be social support. And what we're going to argue over the next 20 minutes or so is actually that we can do things about all of these components, not just about the negatives, we can also try and boost the positives. So for each of these slides, I'm going to show you, describe in a bit more detail some of those individual elements. And on the right-hand side of the screen, these are some quotes from members of leg clubs, patients in clinics, people under your care, whatever phrase. These are sort of quotes that we've found out when we've done some research. So pain may be continuous because of the wound, it may be intermittent, it may even be at rest. It may involve the actual treatment itself. There may be pain associated with that. And there are all these different types. So on the right-hand side, I said I'm not really going to go through these quotes. They're there for you to read. I hope you can read them, even at the back. It was the pain of the treatment that did it for me. All day, every day, it was painful. These are probably quotes that you come across in your everyday practice. Not a surprise to many of you, if not all of you. In terms of the treatment itself, people report that it's uncomfortable, it can be inconvenient, embarrassing or painful. We all know that at the other side of those closed doors there are modern advanced treatments being developed, but still some people complain. There may be exudate coming from them, they may be embarrassed about wearing some of these treatments. The middle quote there, the dressing was large and obvious. All of these have an impact upon well-being. So you've got the pain of the physical wound itself, and then you've got the pain or the psychological consequences of the treatment associated with that. Similarly, the wound itself, there may be wound odour, there may be visible wound drainage, and as I was saying before, There may be wardrobe adjustments to accommodate the dressing itself. A quote that I always provide is that we interviewed one lady in Wales who said that, you know, she was of an age, she liked to wear dresses, she didn't like to wear trousers, but the dressing was on her leg, so she had to try and accommodate that or hide that dressing. So she was in this dilemma. Should I wear trousers, which I've never worn in 70, 80 years of my life, or should I wear a dress and have the embarrassment of the dressing? There may be mood disorders. Again, it's commonly reported. Previous research has sort of indicated that there may be depression, anxiety, and various other sorts of psychological problems associated with chronic wounds. There may be also problems with body image. People have to reconstruct, it's known as psychological reconstruction of the self. They have to reinterpret themselves as a person living with a wound. And sometimes what can happen is that the person doesn't see themselves anymore as a person. They see them as a wound first, and then a person second. And we all have a role, if not a duty, to try and overcome that and prevent that from happening. As I said, there may be stress or worry. There may be anxiety about job if people are working, or more likely social interaction, the outcomes of treatment. People with a wound are not going to be as knowledgeable as you. In the first instance, they don't know what's going to happen to them. You have to educate them, teach them, take them through that. The middle quote I think is quite interesting. We had one lady who said, I used to have panic attacks when the community nurse, came to change the dressing. She was so worried and anxious about the pain of the treatment dressing that she was getting herself into a right state. And there may be a frustration about uncertainty about the appearance, the diagnosis, the prognosis. How long is it going to last? Is it going to fluctuate? When am I going to be cured? Is a typical sort of question. And again, the middle quote, I never really knew what was going to happen. Similarly, we've got stigma. All of these things can sort of lead to stigma associated with a person. There's both, I've listed two there, sort of enacted stigma and felt stigma. Enacted stigma is when people are sort of stigmatised because of their condition, and felt stigma is irrelevant whether that occurs or not, whether the person feels that they are being stigmatised. And actually that one may be the most important. So again, a quote that I always provide, again, a lady from one of the South Wales valleys used to go to chapel on a Sunday, and the people, a couple in front of her, were saying, there's a terrible smell in this chapel this morning. It must be those mice and the rats. And she suddenly thought, no, they're talking about me and my leg, with the odour associated with it. They weren't, but it's the way that she felt, and she felt that she was being stigmatised. And because of all these sorts of reasons, there may be isolation. Isolation from families, from friends, maybe decreased mobility, and there may be fear that they'll be trapped because of sort of negative, I put here, negative pressure wound therapies, NPWT, VAC or TNPs. You know, with that particular treatment, individuals feel that they can't move, they can't go out, they're cumbersome, they're tied to the home. Because of all that, it can sort of impact upon the family. There can be both an emotional strain on relationships, so the family feels as if they're burdened in a certain way by that individual with a wound, or there can be a sort of a practical strain. They have to take the person shopping, they have to take the person out, they're a drain on their resources. So, what I've talked about so far is that well-being is negatively influenced by physical, social and psychological factors. But, as Penney sort of indicated earlier, there are positive factors as well which we can try and protect against. So if we can reduce the negative ones and improve the positive ones, then so much the better. I think I'll pass over here for Penney to talk the positive side.
Thank you. Okay, so, as we said, we think there are lots of mediating variables that help people improve their well-being. And that's the sorts of positive things that I'm going to take you through now and talk about in a little bit more detail. So one of those first things is this idea that personality itself can be a protective factor. Now, you might be thinking, why is she talking about personality as well as talking about things that we can affect and influence? Surely we can't change personality. Well, let's come to that in a minute. I think the first thing to say is the idea of the personality that's often termed the hardy personality. You know those individuals, I'm sure those of you who work in a clinical setting, you've come across them. We talked about it a little bit yesterday in the workshop. Those people who always seem to be okay and be positive in the face of adversity. There's a lot of work being done in psychology around the hardy personality. A lot of work looking at the outcomes for those individuals and how we would define a hardy personality. So to give you a summary, those kinds of people in psychology are conceived of having a very positive cognitive style, which means that in the face of adversity, what they do is they don't talk about how terrible and dreadful this situation is, but they look at it as a challenge, maybe even an opportunity, a hurdle that has to be overcome, but in a positive way. So the way they talk about the difficulties they have are very different from somebody who has a less hardy personality. So the style of discussion around, as I say, it's more about opportunities, challenges, it's very positive language. Their attitudes are positive as well. Okay, life has handed me this difficult situation, but I'll be okay, I'll find a way around it, I'll see an end to it. So they're optimistic as well. They have the outlook that says, okay, this has happened, well, let's deal with it, let's move on, let's not dwell on this as a very difficult situation. One of the other things that really seems to make them stand out from other individuals is the fact that they feel in control. So again, if you think about it in a patient clinician situation, those patients who feel that they have some input, they're able to have some discussion around the kinds of treatments they're having, they understand what's happening to them, are going to feel more in control of the situation. They're not having things done to them, they're a part of the process. The other thing that makes these people stand out, and this links into one of the other factors I'm going to talk about a little later, is their coping style. So they have a very active problem-solving approach. So, as you can see, lots of positive words in there. A positive cognitive style, positive attitudes, a positive active problem-solving. Now, you might think that personality is one of those things that, well, some people are and some people aren't. We have optimists, we have people whose glass is always half empty. Well, what's interesting is this literature shows that sometimes there's an indication that hardiness can be learnt, that it's not something that's intrinsic to individuals. There's particularly work in childhood that shows that children learn to be hardy. They look at what other people are doing. There's this model of sort of social learning. They see what other people are doing, how other people cope with situations, and learn from that. Now, the thing I want you to think about is, if that can happen in childhood, why not in adulthood? Surely perhaps some of the ways that we interact with people in a clinical setting will make a difference to how they actually feel about things, can impact on the sorts of approaches they take and the way they even think their own cognitive style. If you think about things like cognitive behaviour therapy that's used a lot in psychology, it's about changing the way people think about things. So that's one element of that hardy personality that we could potentially work with. Something else that's been seen as very important is people having hope. And hope is really something that's characterised by being confident that things are going to get better. And it's about being able to look to the future. And the reason I think that's very important is the fact that you're not dwelling and focusing on the present and the difficulties in the present. It's looking forward to a future time when things are going to be better. So hope is really seen as quite important. People who search for meaning and have a purpose, it gives them hope. And there are, I'm sure, ways of engendering hope in individuals with chronic illnesses and those people with chronic wounds. And again, it's probably partly around the way we talk to people. It's about looking to other things and focusing on other aspects of life. And undoubtedly, being in a situation where you can talk to other people with the same condition, the same problems, and being able to say to them, well, look, I've got past this, I've moved on, will help to give them hope that they too will be in that positive situation one day. Another important protective factor is something we call resilience. And resilience, again, seen as something that really makes a difference. It's about being positive. And one of the areas that there's been a lot of work in psychology is around things such as people who've experienced some traumatic event. It might be a traumatic event, such as it could be a huge thing like an earthquake. It could be being involved in a war. There's a lot of work with war veterans around this. And one of the things that's been noted is that some people have that experience. Two people have the same experience. One person will have mental health problems. They might have experienced post-traumatic stress disorder. Another person in the same situation won't. And so it's taught that it's discussed the idea that that person who doesn't have those mental health problems is resilient. For some reason, they cope with the situation in a very different way to another individual. One of the things that we're often told that we have to take note of is that someone who's resilient is somebody who doesn't have those mental health problems. So we're talking about those people who don't get depressed, anxious, etc. And that's very different to recovery. Now, I think there's a fine line here because actually there are some individuals who we know will recover much quicker in psychological terms than others. So they may feel anxious, worried and depressed initially when they're given a diagnosis, but they get over that quite quickly. The literature is quite clear that they're not resilient people. I'd question that. I think there are probably levels of resilience and there's a continuum. So again, is there something that we can do? Can we work with this to help people to take a more sort of resilient attitude and approach? One of the other things that I said we would be coming to is coping. And obviously, as I said, this links into personality and some of these other factors we've talked around. So active coping is very important. And one of the essential things around coping and coping style is that those people who cope well, who are able to be solution-focused, if you like, tend not to see their diagnosis as a part of them. They see it as separate and outside. So they don't conceive of themselves as somebody who has, whether it's epilepsy, diabetes, whatever the chronic illness is, they don't define themselves through that. It's just one part of them. So they're able to externalise that, and it makes it much easier to come up with a range of solutions to a difficulty or a problem that enable you to be in control again. There's that thing of being in control of things. So you don't ignore the fact that you have this problem. You don't pretend it's not there and just try and carry on as normal. You look at it, you evaluate the situation and say, okay, things are slightly different for me now. What can I do? How can I confront this particular problem that I have now and find a new way of doing the things that I usually do? So it's about that sort of positivity. I think one of the other sort of important things is obviously around social support. And as Dominic said, some of the work we've done some interviews with people in Wales, and we found some very positive sorts of attitudes. And I think those are obviously really important. And one of the things we found when we've been into places like the Leg Club is the fact that people make friends. They have an opportunity to sit, to talk, to be with other people. And I think one of the positive things around that is that it's almost that having a cup of tea and having a laugh. Being able to talk to other people. It might be partly because they're in the same situation, so you can gain things like hope because perhaps they've been through what you've been through, come out the other end. But sometimes it's just about being with others, talking to others, and actually getting that good social support. So, at this point, just to prove Dominic wrong, I'm going to pass it back to him to show that he can do the intellectual stuff as well.
Well, I certainly can't. Because what I usually do at this stage, and for this slide, is say, this is how it all works, and then flick on to the next one. This is a model. Psychologists like models because they've got little arrows and boxes and little round circles at the bottom. But in essence, what we've integrated here is a typical model of something known as psychoneuroimmunology, how the way you think can affect the way your psychological and physiological responses, and therefore impacts upon your health and your well-being ultimately. So at the top there we have the stressors, which I talked about, the pain, the social and the psychological factors. In the middle we have protector variables that Penney talked about, coping, hope and resilience. If those are imbalanced, so the stressors, the pain, are higher than the the protective variables, and that can lead on to psychological stress. Ultimately, through one of three different routes, whether it be the neurological route, the psychological, or the ANS route, you end up with impaired wound healing. So what we're actually saying, as I think we all said yesterday, is that psychology has a key part to play in preventing or speeding up wound healing. And therefore, psychology is the most important thing in the whole wide world. Again, I do keep saying that, but I'm duty-bound to say that as part of the Psychology Club. So what we've done on this, and again, this was over a bottle of wine or two, we put together a model of how we sort of conceptualised it. So what we've spoken about so far are the sort of the yellow things, which are those pain, symptoms, treatment, the social impact. And if you look at all of those things lead on to both quality of life and well-being. However, quality of life doesn't seem to take into account any of the mediating factors, those factors, the red factors, that Penney spoke about. All of those things can lead on to the psychological outcomes, those factors that I just showed you on the model. And if you can see, it goes around in a big loop. So ultimately, if you have poor well-being, poor psychological outcome, you may have more symptoms, more pain, more social impact. So you have to try and boost the mediating factors to try and prevent that circle from developing. And ultimately, a little flash bit of graphical movement coming up, what we argue is that we have to try and forget quality of life because that's an end point. We have to look at well-being because in that way we can prevent this circle from deteriorating throughout time. So this is what I've spoken about. And again, this is a model that we showed you yesterday, or a little diagram I should say, that we showed you yesterday. And we've spoken about this morning. On the left-hand side, we've got the negative factors, those odours, as exudate, psychological consequences, wound treatment. And on the right-hand side, we have those protective or mediating variables. And what we're arguing is that all of us together have to try and boost those positive factors as well as reducing some of those negative factors to try and get it all in balance. And in that way, as you can see, the little graphic hopefully sort of exemplifies that. So, what we said yesterday, what we asked each of the groups to rank what they thought was most important for well-being. And this is what you said. So, or in brackets are the number of groups that ranked it top. So 4 groups thought the most important thing for well-being was good social engagement. Again, you're all at the Leg Club conference, so presumably you all felt duty-bound to say that. 2 of you said good therapeutic relationships with clinicians. 1 of the groups said symptom control, and none of the groups ranked pain reduction as the most important. Again, I think that's quite reassuring, again, from looking at those models from what we said today. If you can boost social support, if you can boost social engagement, then you can improve well-being and it can improve the whole sort of physical outcome. So, this, in terms of the summary, this is what we said today and yesterday. Quality of life and well-being are not synonymous. Quality of life measures the presence of negative psychological variables, whereas the well-being assesses the presence of positive psychological variables. We're trying to advocate a positive model approach to this. They're not on the same continuum. And if we can do this, if we can promote well-being, if we can improve well-being, can we promote healing? It's been shown in other conditions. I don't see why we should stop there. So, how can we do this? Again, something we spoke about yesterday. We have to deal with those negative psychological, social consequences, body image problems, anxiety, depression. We have to facilitate some of the positive factors. Promote active coping. Promote patient care and control so people have control of themselves. Foster optimism, hope and purpose. And provide or encourage social support. That may come through leg clubs. It may come through family and friends. It may come from church or other chapels or other sorts of religious organisations. It may come from a train spotters club. Whatever, you need that social support. We think it's important, patient-focused, because it improves psychosocial outcomes, which can ultimately promote healing. If you have better psychosocial state, then you have reduced costs associated with that. I did some work last year, a couple of years ago, showing that the costs associated with psychological mood disorders associated with chronic wounds is quite considerable. You won't have those if you can improve well-being. Similarly, you have quicker healing as a result of reduced costs and ultimately, of course, all-round better outcome for patients, which is what we're all striving for. So it has both an economic benefit, but more importantly, a benefit for patients and people themselves. So on that note, thank you very much.